Dr. Seth Gamrad from USC showing you the principles of knee arthroscopy during a case of an excision bucket handle medial meniscus tear. First and foremost principle for me in knee arthroscopy is my indication for surgery. The pain must match the compartment that's painful and must match the MRI. There can be no joint space narrowing on X-ray. Positioning is really critical. We need to be able to see the compartment at hand, valgus load for the medial compartment, varus load for the lateral compartment. Portal placement is critical between the patella tendon, tibia, and the femur. You want to be low to parallel to the tibia, deep and dilated for instrument entry. You want to leave the articular cartilage alone. First, I'm going to mark out the bottom of the patella, mark out the tibial tubercle. And now I'm palpating the femur, the patella tendon, the tibia, and the patella. Those four structures form a soft spot, and we'll put our portals, no secret here, just right in the center of that soft spot. And a good portal to me is going to be between 5 and 7 millimeters. We first marked out that medial portal, mark out the lateral portal. Then I like to come in with some local anesthetic. This does two things. It gives me some hemostasis, and it also tests out my portals to make sure that they're in a good position. I use a standard 11-blade scalpel. First I'll cut the skin, and then we like to come all the way in with the knife so that we make sure that we've incised that capsule. Then we bring in the blunt trocar, and then it's very important to extend the knee before that trocar gets jammed up into the suprapatellar pouch so you don't scrape the patella or the trochlea. We'll take out that blunt trocar, replace it with the scope. First thing we see when we point the camera up is the patella. Point the camera down, we see the femur bone. Once we've looked at the patellofemoral compartment, I like to establish my anteromedial portal under direct vision. You can see there right in the front of the knee is a bucket handle medial meniscus tear. We first come in with the spinal needle, 18 gauge, followed by an 11 blade, followed by a snap to really dilate that portal open so you have ease of instrument insertion throughout the rest of the case. Then I like to bring in a small shaver and perform a localized synovectomy right around my portal. Give us a really good look at that bucket handle tear. Now this is somewhat of a chronic bucket handle. You can see the tissue is somewhat shredded, and it really is mostly in the white zone. And I'm not sure that that's repairable. Maybe there's someone out there who can fix this, but it doesn't look repairable to me. So the first thing I do is I take arthroscopic scissors and detach the anterior portion of the bucket, meaning I'm detaching the torn fragment from its attachment anteriorly. Then I come in with a grasper and I tug this thing both posteriorly and laterally, and then come through with that same arthroscopic scissors through the same anteromedial portal. So I've got that tissue on tension, and then I'm cutting it while it's being held with that grasper, hopefully to minimize the amount of stump that I have left to resect. So here's that stump that I'm resecting, and once we've resected it, you can see we've got a pretty clean meniscal remnant. Maybe he's lost about 20% of his meniscus, but you can still see he has a very viable posterior horn. Then we look at the ACL, and then put the knee and varus, look at the lateral compartment, which looks excellent.